Okay, looks like everybody's here. Hello everyone, and welcome to today's webinar, which is being hosted by the ISSUP UK in conjunction with Build on Belief, Phoenix Futures, Change, Grow, Live, and Working with Everyone. So a lovely range of organisations. Today we will give you 3 presentations from these organisations working to challenge the stigma experienced by individuals who have or have had a substance use disorder in the United Kingdom. That will be followed by a Q&A session to look at successful evidence-based strategies to tackle the issue. I'm Tim Sampi, I'm the Chief Executive of Build on Belief, which is a London-based lived experience recovery organisation, and I will do my best to keep some sort of order in chairing the session today. While we're waiting for a few more people to join, I'll say a little bit about the ISSUP. The ISSUP is an international network that unites, connects and shares knowledge across the substance use prevention, harm reduction, treatment and recovery support workforce. Their global mission is to make the work of their members as impactful, accessible and effective as possible. They do this by making it easier to discover and share evidence-based knowledge, best practice, training and networking opportunities. If you've not already done so, please head over to the ISSUP website, which is at issup.net, where you'll find information on how to sign up for free membership. The website also has a wealth of resources and publications for you to check out. Now, before I get started, a couple of things to go over so that you know how to participate in today's session. You will have the opportunity to submit text questions to our presenters by typing your questions into the questions pane of the webinar interface on your screen. On my screen, it's on the right-hand side. You may send in your questions at any time during the presentation. We'll collect them, but we'll address all of them at the end of the session. So we're going to do the 3 presentations without a break. We'll collect all your questions, and then at the end, we will select questions to ask our lovely group of panelists. A recording will be made available for you to watch on demand after this event, and I hope you'll stay with us for what promises to be an interesting insight into the challenges around stigma. Now, I'm delighted to tell you a little bit more about today's webinar and introduce you to our speakers. We'll first play a presentation pre-recorded by Chris Barnes, followed by presentations by Karen Biggs and April Wareham. Chris has had over 5 years of experience as the National Service User Involvement Lead at Change, Grow, Live, and he applies health psychology principles and practices to enhance the well-being and recovery of service users. Change, Grow, Live is a leading charity that supports many people across society affected by substance use. So we'll begin with Chris's pre-recorded video. And hopefully in a second or two, because it takes a moment to load, here it will come.
Firstly, I'd like to say thank you for giving me the opportunity to present. My name's Chris Barnes and I'm the National Service User Involvement Lead for Change, Grow, Live. Change, Grow, Live is the largest third sector provider of drug and alcohol services in the UK, and today's presentation is titled Overcoming Stigma within Change, Grow, Live.
So today's presentation will cover, well, firstly, I'd like to start by talking about stigma in the context of drug and alcohol use. I'll introduce Change, Grow, Live as a national provider of drug and alcohol treatment services. We'll briefly talk about the 10-year drug strategy and how this is creating opportunities for people with lived experience of drug and alcohol use to influence. Then we'll talk about service user involvement. So how are we gathering the voices of the most marginalized and stigmatized within society so that we can ensure that they have a say in the decisions that affect them. I'll share some examples of where service user involvement has brought about positive change, and then we'll move on to questions and close. So since the introduction of the Misuse of Drugs Act 1971, within society, drug use has been perceived as an immoral choice, and the use of criminalisation and punishment of people using drugs has been used to dissuade others from doing the same. This approach has created social divisions and informed negative stereotypical perceptions towards people who use drugs and alcohol. People problematically using substances remain one of the most marginalised and stigmatised populations within the general public, and stigma acts as a barrier to engagement with treatment services, and it affects the perceptions and views of staff and organisations that are there to support people who use drugs and alcohol. Stigma can inform actions and behaviours which can be discriminative towards this population. Since the introduction of the Misuse of Drugs Act, we've had the introduction of the Novel Psychoactive Substances Act, and now there are more illegal drugs and substances than ever before. Drug-related deaths and harm are at an all-time high, which leads many to conclude that the war on drugs has not worked. And within the 10-year drug strategy, it is acknowledged that evidence-based modern interventions are needed, and there is a need to integrate services to meet the needs of those that are affected by problematic drug and alcohol use. Opportunities to better understand substance use and the populations affected have been limited by stigmatization. We're currently heading into the 4th year of a 10-year drug strategy, and one of the most effective ways to make decisions to better meet the needs of people using drugs and alcohol is to listen, understand, and respond to what they need. This is particularly important for organisations working to achieve the 10-year drug strategy and meet the needs of the people who are affected by problematic drug and alcohol use. So Change Grow Live is the largest third sector provider of drug and alcohol services in Europe, and we have over 100 services which are located across England and Scotland. We support 200,000 people a year, and the support that we provide is focused on prevention, treatment and recovery. And we provide support in a range of different areas, so this includes homelessness, criminal justice services, employment, smoking cessation, children and young people services, domestic violence, family services and prisons. We support a lot of people who are the most marginalised and stigmatised within society, and like many other organisations in the same position, we joined the Anti-Stigma Network in 2023. As an organisation, we realise that our value is created when we respond to the needs of the people we serve. But to do this, we must first listen and understand people's experiences and needs. The statement seems simple, but in practice, understanding and responding to people's needs, especially in the current climate, is extremely complex. In the past few years, we've seen how complex this is. We've had the cost of living crisis following COVID, inflation, increasing health inequalities, and now the availability of novel synthetic opiates. Since COVID-19, drug-related harm and death have increased, and people are engaging with services with greater health need than previous. There have been major changes to the drugs that are used across the country, and we've seen increases in ketamine use, particularly in children and young people. And we've seen an increase in the prevalence and strength of cocaine, increased benzodiazepine and prescription medication use, and increased alcohol use. And this is changing all the time. The context constantly evolves. And so therefore, to meet the needs of the people accessing our services, we must continually listen in real time to what they have to say. And this is the approach that we've adopted within Change Grow Live. So the developments around service user involvement feedback methods actually began at the end of 2019, so just before COVID-19 and the lockdowns. And we undertook rounds of consultation with staff and volunteers across Change Grow Live. We used the COMBI model of behaviour change, which is an evidence-based framework by which to gather feedback, and we engaged with staff and volunteers to understand what are the barriers to listening and responding to people who are accessing our services. We were extremely fortunate to have started this work early because obviously at the beginning of 2020, lockdowns began, and there were some significant changes to service delivery. We moved to online forms of support, and we made some changes to the way that we prescribe to some of the people that use our services. At the same time, the typical ways that we were gathering feedback from people accessing services stopped. People weren't coming into services, which meant for a period of time it was actually quite difficult to understand the experiences of people who were using our support and services. Through the consultation, it highlighted that staff teams across the services did not know how local feedback influenced national change. They struggled to find the time to get feedback, and typically it was one person in each service that was designated with gathering feedback, and on many occasions they felt that the support from the wider staff teams would improve the gathering and application of service user feedback to inform service delivery. The consultations also highlighted that staff were unsure of the different mechanisms by which service user feedback could be gathered, and this work led to a series of recommendations. We began work to develop a few different methods of gathering feedback, and this included a qualitative open-ended service user pulse survey, and we also developed a quantitative measure of satisfaction and involvement with decision-making within the treatment outcome profile form of the National Drug Treatment Monitoring System. Together, these methods were piloted across 4 services, and training to staff teams was developed and provided. The mixed method approach worked. We were able to compare and contrast service user experiences across 4 locations, and this helped to provide assurance around service delivery and also provide insight into areas for future co-production and development. To increase support for service user involvement within our services, we created a service user involvement policy, and this meant that the gathering of feedback and responding to feedback was every staff member's responsibility. We also created a service user involvement guide, and this helps staff teams to understand the different feedback methods available and how this data and feedback is used to inform organisational decision making. In 2021, the government's drug strategy was released, and the strategy outlined the need for genuine co-production and lived experience, and it increased the value of service user voice. Additional changes, such as the way that CQC changed the way that they inspected services and the latest development of combating drug partnerships within local authorities, further increased the value and need for service user feedback and lived experience. From 2021 to the current date, we continue to work and implement and develop new feedback methods, and we've created a range of different lived experience groups to enable those with lived experience of drug and alcohol use to help gather and use the feedback received to help inform decision making at local and national levels. By doing this, lived experience groups are able to accurately represent the views of people accessing services and understand the views of many more people who use the service. We acknowledge the impact of stigma and how this can limit opportunities for people to be heard, and we continue to develop new ways to develop feedback to hear more voices from people who use our services. For example, only this month, we've just started looking at our own web chat data for people who are not currently accessing services, and we've been able to use artificial intelligence to analyse large amounts of information that's been received through this. This is helping us to understand the needs of people who are still reluctant to engage with treatment services. So as mentioned at the beginning of this presentation, we support 200,000 people who are affected by problematic drug and alcohol use each year. We found a way to standardise the way that we can gather feedback across all of our services, and we're able to hear more voices than ever before. And remember, this is a population that are the most marginalised and stigmatised within society, and we're able now to hear a good proportion of these in real time, and it helps us to understand the needs of the majority of this population. Through this, we can gain assurance around service delivery, we can understand what needs to improve, and we can advocate on behalf of the people we serve with confidence. In addition to gathering data and feedback from people accessing services, we also use lived experience. We actively recruit people that have lived experience of problematic drug and alcohol use, and 40% of all of our volunteers have lived experience. This helps engagement with people accessing services, and it helps us to understand the needs of people who use drugs and alcohol better. We know that drug and alcohol use and the people that use drugs and alcohol are extremely varied. They have different experiences of different substances at different times. And through the 10-year drug strategy, there is a big demand for lived experience to help inform decision making. But equally, it's important to ensure that you have the right people with the right lived experience to inform the relevant decisions. And so, to increase access, we've created a national lived experience network. This network consists of people with lived experience who are willing and able to support national work streams. They've provided us with permission to be able to contact them, and when a relevant work stream emerges, we're able to draw upon their expertise to help inform the decision making. And this has really helped to increase access to relevant lived experience in real time. With the large amount of information that we've received and feedback, there have been a lot of service user-led developments within Change Grow Live, and I'd like to share a few of them with you now, including how this has helped to combat stigma that's experienced from the people that use drugs and alcohol. So firstly, I previously mentioned the artificial intelligence that's been used to analyse web chat data. Before we started trialling that this month, we'd done this manually on a few occasions. And what we found was that for the majority, they weren't actually seeking support from services, but were problematically using drugs and alcohol. And when we looked at the transcripts, we were able to identify anxieties, the worries, the information that people needed to be able to engage with services. There was a lot of uncertainty about what would happen. People thinking that they would lose their kids, there would be social services involvement, all of these worries, and we were able to sort of see this in real time. What we've been able to do in response is to update information that's on our website and the materials that we provide to sort of alleviate some of these anxieties and concerns that people have, which should and hopefully has helped to increase engagement with treatment services. In addition to this, we also looked at what substances people were using over time. And over a number of months, we analysed and manually transcribed transcripts, and we found that there was an increasing amount of transcripts coming through for cocaine, alcohol, and benzodiazepine use. We reported this, and we kept an eye on it. We didn't have 100% confidence, but we were quite sure we were onto something. And then a few months later, through official channels, increased benzo, alcohol, and cocaine use was identified, which gave some assurances around web chat being a really useful method to understand unmet need and the anxieties and concerns that people have who aren't engaging with services. During COVID-19, we relaxed prescribing, we switched to online forms of support. And for the majority, these changes were welcomed. We found that people no longer had to go to the pharmacy on a daily basis, and they were able to manage their own lives, gain employment, see more of their family, and they were able to get access support without long, costly journeys to treatment services. Realising the benefits to some, we published research to capture how these experiences had been positively received by people who were using our services. Through our Service User Pulse survey, we've been able to understand in real time the impact of the cost of living on the people that use our services. People are having to choose between employment or receiving support, and so in response, we've developed a new telehealth model in Hertfordshire. And this helped those using substances at less harmful levels to receive telehealth support. We robustly evaluated this service, and it showed that it's been well received by people who use the service and has led to a range of positive treatment outcomes, particularly for those who were disabled or unable to access the service in person. In 2021, we realised that health inequalities were increasing, and we know that conditions such as cardiovascular disease, COPD, and diabetes are extremely prevalent within the people who use drugs and alcohol and the people that we support. We undertook a piece of research in collaboration with other providers, and what we did was we set out to understand the barriers to engaging with health screening. For the NHS's long-term plan, cardiovascular disease, diabetes, and COPD are a priority area, and we know it's very prevalent within the people that we serve, and so we undertook this research to help advocate on their behalf and share this with others so that we can find better ways of integrating services and meeting need. Populations of people using drugs and alcohol, they're made up of many other smaller groups. There's different substances, different people, different populations. And so what we do and what we've done is we regularly focus on specific populations to undertake research to understand barriers to engagement with treatment services. And we've done this for women and UK Armed Forces veterans. And this has led to some significant developments to our organisation and the delivery to those populations so we can better meet their needs. Along with this presentation, I've provided a case study, and this case study outlines some of the work that's been done in CGL Nottinghamshire. So this was one of our first services to pilot and embed the service user feedback methods that have been shared within this presentation. Through this, the service has been able to advocate on behalf of people accessing the services, and the Combating Drug Partnership has renamed itself, removing the word combating, which is fantastic. It's reviewed the language that's used when discussing people who use drugs and alcohol, and they've acknowledged the importance of actually feeding back to the people who use drugs and alcohol about what can and cannot be done in response to the feedback that they provide. Currently, this is one of the most developed drug partnerships within the country, and I hope if anybody's interested, you can have a look at the case study that's been sent along with this presentation. In a number of areas, lived experience groups have come together, and they've helped to create like media and documentaries to help educate others about problematic drug and alcohol use. In St Helens, which you can see on the screen, this is a documentary titled Sticks and Stones, and it's all about stigma and how it's experienced by people who use drugs and alcohol. These have been fully co-produced with people with lived experience. The other documentary there is The Domino Effect, and I think both of these can be found on YouTube if you're interested. But it's a great way to educate others about the realities of drug and alcohol use. Documentaries like these have helped to increase awareness about drug and alcohol use and the wider determinants of substance use to others within society, and this can help reduce the stigma that's experienced. But to do this, we need to be able to work together with other organisations, so greater collaborative working where we can share and advocate on behalf of people using drugs and alcohol. And it's only through doing this that we can really make a change within society and reduce the stigma that's experienced. So, to summarise, stigma has prevented people from speaking up and being heard. And in response, we've developed an evidence-based approach to gathering feedback from all of our services in real time. As a result, we now have access to more feedback than ever before, and we can confidently report on local and national trends in service user experiences and need with confidence. We're continuing to increase feedback to further maximise confidence in what we report, especially when we share this with other decision makers, especially those in combating drug partnerships and central and local government. We want service user feedback and lived experience to have the maximum impact that it can, and we continue to work with different academic institutions and universities to further evidence-base the service user voice and ensure that it is heard and influences change, especially at policy level. The approach used within Change Grow Live has been shared with other providers of drug and alcohol treatment services, because in doing so, the more that we can hear the voices of those who are affected by drug and alcohol use, the more that we can make positive change to benefit them and the organisations that support, as well as wider society. We do have some research planned in the future, and this research is in partnership with Liverpool John Moores University. And what it seeks to do is to measure internalised stigma across people accessing support. And then what we're going to do is we're going to be looking at to what extent does internalised stigma affect treatment outcomes, and we'll be looking at the differences that gender, age and substance type make to those relationships. We expect this to begin towards the end of this year, and our findings should be available by April 2025. As always, we welcome opportunities to collaborate and undertake research with other organisations, and if anybody is interested in collaboration, please contact Change Grow Live's central research team using the email address contained within the PowerPoint slide. Thank you for taking the time to listen to this presentation. I hope you found it interesting, and if anybody else would like to know more about anything that's been covered, please don't hesitate to contact me or my manager, Director of EDI, Simone James, using the email addresses contained within the PowerPoint slide. Thanks again for taking the time to listen to me. And that brings us to questions.
Thank you very much, Chris. It's always fascinating to hear what someone as big as CGL is doing to take stigma head on. Those lovely people listening, remember, pop your questions in the chat and we'll get round to them later. Now, our next presentation is by Karen Beeks. Karen is the Chief Executive of Phoenix Futures. Her earlier career was in supported housing and homelessness. As Chief Executive, she's responsible for making sure Phoenix does exactly what it says it will. She's a great believer in the charity sector and its roles in supporting people that the state can't or won't help. And she's the trustee of a number of charities outside of Phoenix. Karen has also been central to helping to put together the Anti-Stigma Network in the UK. So Karen, it's all yours.
Thanks, Tim. And just at the last minute, I've gone and messed up my presentation. So if Quado's there, I would love you to jump on and help me. But can you see that, Tim? Can you see my presentation?
You can see your screen. It's presentation is all up and working.
Brilliant, thank you. Okay, so hello everybody, and thank you for hosting the seminar today, and Tim for sharing it. In my presentation, I'm going to introduce the Anti-Stigma Network, our aims and our approach, and then spend a little bit of time talking about the work we're doing now and that we plan to do in the future. But before I start, a note on language. The Anti-Stigma Network aims to address stigma by calling out discriminatory practice and creating more opportunities for inclusion. The use of language matters in all of our work and our conversations. And there's a general consensus about the words and phrases that may, in certain contexts, perpetuate stigma. However, language is complex and intent and context can change meaning. I prefer people to speak freely than to fear speaking at all. I also recognise we're all learning and collectively developing our understanding around stigma. I sometimes get it wrong, but I'm very happy for people to tell me when I do. So what is the Anti-Stigma Network? For decades, many organisations have been working to tackle stigma directed at people who use drugs and some people who use alcohol. It's no longer socially acceptable to stigmatise against people with mental health conditions or people who have experience of domestic violence, although we know that still happens. However, society's attitude towards people who use drugs hasn't changed much over time, and we continually see examples of overtly stigmatising language and policies across media, health and social care policy domains and social settings. Much of it is often unchallenged. If we're to make real progress in helping people whose lives are impacted by addiction, we need our governments, our media, our public servants to understand stigma, how it's created, and the pernicious effect it has on so many people's lives. This work will take time, and a commitment to a longer-term project is required. If we're committed to ending stigma, we all need to act and to ensure our work doesn't inadvertently or purposefully perpetuate stigma. Last year, we started a conversation about what a combined sector approach to stigma could look like. We talked to people with direct experience of stigma, people who deliver services, academics and people leading anti-stigma initiatives, and we agreed to come together to create a steering group. And last April, we created the Anti-Stigma Network. Our mission is to end stigma, and some people say that can't be done. Our view is that our ambition can't be anything but to end the discrimination faced by people that limits opportunity to thrive in life, that creates inequality and takes away people's human rights. If that's what stigma is, how can we say we're committed to anything but ending it? We'll do it by collaboration and by co-production. We won't always get it right. We'll make mistakes, and we hope to be able to learn together. We know it will take time, so whilst we're impatient for change, we're committed to doing this for the long haul. Our approach is rooted in lived experience. We've worked with people with different life experience of stigma to help us create the network, from the initial idea to the aims, the branding, the content, and the overall strategic direction of the work. You'll see stories on our website. We're moving past the case studies to demonstrate a point, and we're telling stories of people's lives. They're stories of people's lives where drugs and alcohol are a feature, but the drugs and alcohol aren't the story. This is a powerful way to educate people on what stigma is, the shaming, prejudice, and discrimination people face in accessing health, housing, employment, and the policies and procedures that make it difficult for people to create the life they want. We hope the stories we share provide opportunities for us all to understand how we can take an anti-stigma approach to our work and to our lives. We aim to help amplify the huge variety of existing anti-stigma work across the UK and the world, enabling us all to maximise our shared effort to take action to end stigma. We're careful not to compete or detract from the work that's already taken place. So how can we fight stigma? We believe you end stigma by naming it, understanding it, fighting it, protesting against it. And we've developed this approach using research findings and practice from across the world. When we started the network, I was clear that stage one needed to be the health and social care sector. We needed to get our own house in order before we started to try to change the wider world. We asked our focus groups what they thought the priority should be, and they were really clear that the stigma that they experienced within A&E and GP surgeries specifically was critical and an overwhelming barrier to getting access to healthcare. Healthcare that would save their lives in many instances, but would also mean that their healthcare condition, drug and alcohol related and non-related conditions, would be left untreated until they became critical. They thought That was where our attention was best focused, in these areas of our healthcare system, to create the maximum impact. We started the work working with healthcare professionals and the people with lived experience to identify and understand stigma, how it occurs, and to find ways to address it. There's much more work to be done, obviously, but the picture emerging is one that will be all too familiar for many. Workload pressures, poor communication, and stigmatizing attitudes leading to ineffective care responses. Staff become desensitized and systems and processes fail to meet need. And the impact of all of that is that people are discharged to free up beds before their care is completed. People are stuck in the wrong setting due to lack of joined up care. People are self-discharge or walk out or are removed by security from A&E. All of that has an impact on patient safety. As people are exiting care before treatment is provided or completed, patient safety is compromised. The care needs are not met. It doesn't seem that safety procedures such as complaints review, advocacy, reflective case reviews are working well for people with substance use needs, possibly because patients are more likely to be blamed themselves, or that substance use isn't seen as being the responsibility of those healthcare staff. Hospital processes aren't designed for people with multiple health and social care needs. So patient safety declines and stigma increases. We've been advocating for a man recently, and I'll call him William. He's had 104 hospital visits in the last 2 years, inpatient admissions and A&E attendance. That's not because William is treatment resistant or hard to reach or choosing a life of dependency, but because the local system, the people that work in it, aren't meeting his needs. They're overworked, they're stressed professionals, failing to link pathways and optimise the services we have and innovate to fill the gaps. So what can we do? Staff training is vital to improve awareness and to help teams develop appropriate care responses. Reviewing complaints through a stigma lens could help provide some insight. Improving our communication and our coordination of care and ensuring the right people are involved at the right time. Effective advocacy is a must in this situation, and addressing stigma in reflective practice and incident reviews would really help to build that empathy and insight. The Anti-Stigma Network can help with much of that, so please do get in touch if you would like to pilot stigma reduction practices and actions. A little bit of stigma is a good thing was an approach taken by the previous government and underpinned much of the actions and approaches in the drug strategy. However, the strategy itself also set out an ambition to address stigma. Since the election, we've been hopeful that the new government would take a more coherent and evidence-based view to stigma. We've highlighted already to them issues relating to language in recent government media briefings. And our sense is that the little bit of stigma is a good thing approach of the previous government is out of step with many individuals, organisations and public bodies working with people who use drugs and alcohol. We appreciate that the crime agenda is central to the government's initial programme of work, and we want to support that. But we're really keen that the government doesn't create unintended consequences for access to treatment or create unnecessary disconnect or potential flashpoints with many who see the damage stigma does. So why join the Anti-Stigma Network? Well, currently we've got close to 1,000 individual members, mostly from health and social care, academic and arts and education projects. And we've also signed up our first 20 organisational members, as Chris mentioned, CGL's one. We've recruited additional staff to help us deliver our approach. We're developing a 3-year medium-term plan to get some funding to expand our work across the UK. In the meantime, there's lots of resources on the website. You can join either as a member or as an organisation, and you'll get newsletters that share information, stories and the latest research. We're running some forums at the moment. There was one today and there's another one on the 12th of November. They're open, informal forums to discuss stigma, exchange ideas and make some plans. So please do get in touch if you'd like to attend. And we also have an early day motion to draw attention to the network amongst our politicians. So please sign that and let's get rid of this little bit of stigma idea from our politics. And if you want to help with anything related to stigma or the work that you're doing, we'll be able to connect you to information or to others in the network that will be able to help. As I said at the beginning, this isn't something that we're going to do overnight. We are in it for the long haul, but we'll only make progress if we all, those of us that care about it, make an active decision to take action. Thank you for listening to me.
Got my mute button there for a minute. Wonderful. Thank you very much, Karen. That was
Has
fascinating.
my screen finished? Has my presentation ended?
It has. It's gone now. Yeah.
Okay.
And remember, anybody got any questions they want to ping in Karen's direction, please feel free to put them in a chat. Now, last but not least, on to April Wareham. April is a director at Working with Everyone, a collection of unique individuals who have both lived experience of social harms as well as professional expertise. They work with marginalised communities and facilitate the NHS England Forum Citizens on the Margins. April advocates for a system that sees people as whole people and as part of communities and lets them set their own priorities. So, April, when you're ready, feel free. Off you go.
Okay, so hi, I'm April and I'm here today to talk about strategies for overcoming stigma. Now, before we start, to make this as accessible as possible for people, and we know that closed captions are not always accurate. Next slide, please. If anyone would like a complete transcript of this presentation, either Word or PDF format, please feel free to contact us. Make sure you ask for the right presentation or you might get something a bit random. Next slide, please. I'm April and I'm from Working with Everyone. We're a group of people with lived experience of marginalisation. We exist to bring the voices of people into the spaces where policy and strategy decisions that will affect them are made. In the last 5 years or so, we've spoken to, you've just gone on an extra slide. Thank you. In the last 5 years or so, we've spoken to a few hundred people as part of consultations, specifically about addictions treatment. And that would be everyone from people who might benefit from treatment in the future through to people who benefited 10 years ago and their family members. We've held 2 or 3 dozen more workshops where people from who use addiction services or might use them in the future are invited to talk about their experiences of healthcare. This poster is from a project we facilitated in 2021, specifically looking at stigma and drug use. Next slide, please. It was for the Addiction Provider Alliance, and we produced a report breaking stigma down and presented our findings at their conference. So the link to the presentation is there. And if you want a copy of the report, email me. So I'm going to be honest here. I'm starting to find stigma a bit boring, so we've been talking about it for a really long time. So as I try to write this presentation, I struggled to come up with a new way to look at the problem. And it's a problem we all agree exists. And I didn't want to present things twice that you can listen to or read elsewhere. Next slide, please. Our first problem was to define stigma. And the definition we chose during the workshops was, if you stigmatize someone, you have given that person a negative label that limits them in some way. And so that was our working definition. Next slide, please. We've heard from lots of people and lots of perspectives about stigma and the impact it has had on their life. We know that stigma causes untold damage to people, families, and communities. The direct results of stigma were people not getting help in the first place, not going back a second time because they got treated badly the first time, people not complaining, people becoming isolated. People talked about doing it anyway. And what I mean by this is a mechanism where people think, well, if you're going to accuse me of stealing or something else, if you believe that about me, I might as well do it anyway, because I'm already being treated as if I've done it. So stigma actually has an impact on people's actions. People also talked about giving up and becoming resigned to poor treatment, accepting that this was the best they were going to get. People talked about not disclosing any more information than they had to. And basically, when all else failed, lying. And eventually being stigmatized becomes your reality. So if you want to hear more about this subject and hear some quotes from the amazing people we met during the project, then please do listen to the presentation. And so during this project, next slide, please. One of my team, Gemma, who's a lived experience qualitative researcher and much better at this sort of thing than I am, broke down the themes from the workshop into the different types of stigma that people reported experiencing. And what we found was that people's experience of stigma was personal and contextual, that not everyone experienced stigma in the same places from the same people and in the same way. It was also cumulative. So what this means is that the way I experience stigma, in fact, it probably will be different from the way someone else experiences it. And so, next slide, please. The types of stigma were defined as discrimination, which is a behavioural result of prejudice. Experience stigma, which is how somebody experiences it. Social or public stigma, which is defined as the prejudice and negative attitudes held by the public or society in general. Anticipated stigma, which is where you expect bias from others. Self-stigma, which is defined as the internalization of prejudice and discrimination from social or public stigma. And perceived stigma, which is defined as the perceptions of how the stigmatized group is treated by others, regardless of how they're actually treated. If you want to read more about it, there's miles of it in that very long report. So, what can we do? We know we need to do something, but we seem to be struggling to decide what to do. Maybe because there's so many things that we could do. So as I thought about it, I wanted to think about the things that were within our gift as a sector to change and those that weren't. So let's hone in on the things we can change, and more importantly, the ones that we can do something about now. The things that have a positive effect on people using our services today, not just in 10 years' time. Next slide, please. So let's just quickly go over the ones that we can't, as a treatment system, affect immediately. The ones that we've got no control over. Social or public stigma. Now, societal change, it takes generations. Think about single mothers and the difference in the way society viewed them in 1950 or 1980 to how they view them today. This is a long-term project. So I'm not saying don't run an awareness campaign or produce guidelines or any of those things. I'm just saying that it isn't going to make an immediate difference to the lives of the people who are using our services right now. Now, as for experience stigma, this is stigma that's already happened. Well, we can't change the past. It's already happened. We can only make sure it doesn't happen again. And as for anticipated stigma, we can't change how somebody feels before they contact us. I could spend weeks or months worrying that I'm going to be stigmatized somewhere. And then, when I finally go, it could be amazing, not stigmatizing at all. The only thing that we can do about that is make sure that when someone accesses our service, they are actually amazing. We can't prevent them being worried in the run-up to it. Can't prevent them anticipating stigma. Although making our services amazing will eventually have a knock-on effect on anticipated stigma, as people will be less likely to be anticipating stigma if everyone they know has told them how amazing our services are. Now, on to the types of stigma we can affect. Self-stigma. You're doing it with the slides again. This is the little voice that says, I won't get that because I'm not worth it, because I'm a drug user, I'm an addict, all that sort of stuff. Now, hopefully, this is something our treatment system is helping people work on. Isn't this the premise of our psychosocial interventions, our CBT and NLP, our rehabs and day habs and groups and one-to-ones, helping people change that internal narrative? Isn't it the whole basis of building recovery capital, giving people meaningful opportunities so that they can feel proud of their achievements? Now, I'm not saying that we couldn't be better at this, because we probably could. But I think by upskilling our staff and looking at our psychosocial interventions through a lens of reducing stigma, I think we can do this. The next one up is perceived stigma. Next slide, please. This one's interesting. I want to tell you the stories of two different groups of service users that I met in the last 5 years. Now, we all hopefully know that the guidelines in the UK state that if someone misses picking up their methadone for 3 days, they need to be retitrated. Okay. So the first place I visited, what people said to me is, I just bollocksed up my script. Now I need to go back in and get an appointment, start again from 30 minutes. The feeling was resignation. They may not agree with the process, they may not agree with the rationale behind it, but they know it's happening and they're totally resigned. Hear the language. I just bollocked up my. In the second place, people said, oh, if you miss your script for 3 days, they take your methadone off you. They cut you down to half or even less than half. They make you go back in. They only treat us like that because we're junkies. They wouldn't treat anyone else like that. The whole feeling was one of outrage. These people knew in their hearts that they were only being treated this way because they're drug users. Now that's 2 areas, both of them adhering to clinical guidance. One action, which is if you miss for 3 days, you have to come back in, but 2 very different experiences. So it's not always just what you do, but the way you do it's important too. Next slide, please. Now let's talk about discrimination and cumulative stigma. So if I go somewhere and find it hard to access a service or get treated differently from other people, it doesn't much matter to me whether you've done it because I use drugs, or I'm a sex worker, or I'm a woman, or I'm a wheelchair user. All I know is how I feel. And I feel like I'm a nuisance and that I'm unwelcome. So I'm going to say, let's get our house in order. Make sure that we're not treating any group in a way that's discriminatory. And in fact, I'd say let's go a step further and try and make our services welcome to people from different communities. And before anyone gets upset and says they're not directly discriminating against any particular community, I don't think most services are turning anyone away based on their protected characteristics. But let's ask ourselves about if our services are truly accessible to people from different communities, if we're truly making them welcoming to the diverse communities we serve. My feeling is that the answer is no. Now, this whole thing is a topic for another time. We can't do it justice in the time we've got. But while we're here on the subject, let's quickly just think of other communities who are not listed as protected characteristics. iPad users, domestic violence survivors, former prisoners, former members of the armed forces, and on and on and on and on, all of the communities we meet. Are our services really welcoming? Okay, next slide, please. Right, I'm going to let you into another little secret. I hate giving conference presentations. Almost every time I do it, somebody feels the need to devalue my experiences, judge my life choices, or to follow me around, both virtually and physically, questioning and criticising my choices. So I've gone through, through the years, I've gone to some effort to make sure I don't get invited back. Once I even dressed up as a witch, and I still got invited back. So here it is. I'm going to give it another try to not get invited back. Let's talk about a stigma that's endemic in the addictions field, the last great taboo. Next slide, please. Let's talk about the systemic and institutional stigma experienced by those who use drugs and don't want to give up. Let's talk about those who've chosen medically assisted recovery, who are on OST, and those that have chosen non-abstinence-based recovery. So hi, I'm April, and I'm in non-abstinence-based recovery. In no particular order, I'm the director of a company. I have a family, a child, a grandchild, a home. I pay tax. I've got a bank account. I'm just about to buy a house. I've got a degree. I own a bread maker. I speak Latin, admittedly not very well. I like calculus. I have 2.4 cats, an ISA, and a bucket full of toads. I'm happy. Outside of the addictions field, by any measure, I am considered a success. Within this field, I am not considered a success because I'm not abstinent from opioids. NDTMS does not consider me a successful completion. If I used any other substance, controlled use would be considered a success, but because it's opioids, it's not. Whenever anyone asks me about recovery, I cringe. Many people tell me to give it time. I'll become abstinent when I'm ready, as if my life is a stop on the way to real recovery. Why has the slide gone on again? The feeling is that if I tried just a little bit harder, I too could become abstinent, as if this is a goal that is more important than anything else I might do with my life. I don't have a problem with people becoming abstinent. In fact, many people that I meet, that's the best choice for them. But I'm tired. I'm tired of people questioning my choices and making a value judgment about my life. I'm tired of people telling me that I'm a risk to other people in recovery and shouldn't be allowed in services. I'm tired of people questioning my ability to do my job based solely on the fact that I'm not abstinent. I'm tired of being told that I couldn't possibly work in the addictions field because I'm not abstinent. Overall, I'm tired of not being considered good enough no matter what I achieve. So now, let me quickly tell you a story about a young man I met about 10 years ago, a service user. He asked me about how long I've been in recovery, and I did cringe. I said, that's difficult because I'm not abstinent. And his whole face lit up. He said, what? You mean you don't have to be abstinent to get a job? It was like all his Christmases had come at once. He'd been in treatment for a couple of years, and nobody had ever told him that he could get a job before becoming abstinent. So, to talk about things that we could do, training for staff, including about the benefits and reasons for giving OST. In over a decade of training staff, I can only count on the fingers of one hand the number of times someone has said that the point of OST is to keep people safe and provide them with stability to move on with the rest of their life. Mostly people speak about OST as a means of becoming abstinent or reducing crime. Some people, when they're given OST, thrive. They have a job, a home, a family, and their equivalent of a bucket of toads. Others are able to use this time to consider what they want to do with their rest of lives and leave and use it as a bridge to becoming abstinent. Language. There's some really good guides about non-stigmatizing language. It'd be nice if staff didn't use language that stigmatized people who are not currently abstinent. Redefining success. Now, to labour this point a bit, because I'm probably getting boring at this stage, is abstinence is not the only marker of success, and it would be good if our policies and our practices and our staff teams reflected this. Volunteering and employment. Some areas have done some really good work developing pathways through volunteering to employment for people who are not abstinent, admittedly not in the drugs field, but people are moving through volunteering and getting jobs. I still find it really annoying that some services make engagement in the labour market contingent on abstinence. Lived or living experience. We talk a lot in this field about the value of lived experience or living experience. We need to truly value both, and we need to involve people who are current service users in the design and evaluation of our services. I've been told in the past that I'm unable to be part of a service user group if I'm not abstinent, in case I put other people at risk. I remember a service user group a few years back deliberately recruiting a number of people who were currently using drugs and alcohol. I went back a few months later and asked how it was going. I was told that unfortunately they had to suspend the new recruits because they were using drugs. Okay, so that was the sound of my toads running away as I banged my head off the desk. I'm so upset, I'm actually losing my toads. This area had recruited people because they used drugs and then suspended them because they used drugs. Okay, next slide, please. Please note that the toads were a metaphor and that no toads were harmed in the making of this presentation. Thank you for listening. Next slide. Please feel free to contact me, but don't ask me to speak at conferences. Thanks, everyone.
Excellent. Well, excellent. Well, look at that. 3 really, really interesting speakers, 3 really interesting viewpoints, and some fascinating work that's taking place here in the UK. Now, we're a little short on time, but we started a little late. So I'm going to have a look at questions. Oh, it's very small. It's going to take me a minute. Oh, questions. Where are you? Yeah. Okay, let's try this one.
Right under the webcam tab. Should see all the questions.
I found it. I'm just having a little look. I should have looked beforehand, to be honest. Okay, well, here's one. Let's start with something really simple. I I'm going to give this to Karen. Karen, why do you say alcohol and drugs when alcohol is a drug?
Okay, to try and clarify what I'm talking about. There's no value judgment about whether alcohol is a drug or not, but just to try and give some greater clarity around what I'm talking about.
Fair enough. Good answer.
I could say alcohol and other drugs.
You could, and we will. Okay, my next one. This is for you, April. Don't lose the plot. The question is, can stigma be a motive for a person to do his best to begin the journey of recovery? Can it be a crucial social factor?
Oh my God, the toads are everywhere, Tim. Right, so short answer, no, I think, because people are stigmatized enough, they're not getting help that they need because of stigma. So increasing that stigma, Karen touched on it in her presentation as well, is not helping. And the other thing that is not helpful is, as a field, we generally accept that addiction is a chronic relapsing condition, and that when somebody relapses, that additional stigma prevents them coming back.
Thank you.
Codes.
Good answer. So I'm a man and I don't do multitasking very well, so I'm trying to read and listen to you at the same time, which is not particularly easy because I'm just not that bright. Okay.
Can I just add to that, Tim? And I think it's a really important, even if it's the only point we discuss. I think it's a really important point for us to continue to talk about, because it is there is a view in the world that a little bit stigma is a good thing. If we agree that stigma is actually prejudice and discrimination, would we say a little bit of prejudice and discrimination is a good thing? I can't believe that anybody who was trying to do good in the world would say that. And so there is no evidence base to show that stigma changes behaviour in any area of life. There's more on this on the Anti-Stigma Network website, and we will certainly, if you get the newsletters, it's quite a current conversation as well. So whoever asked the question really would be keen to continue the conversation. But I do think as a sector, it's something that we need to agree a position on, because politicians will use it for their own means, and that isn't necessarily going to improve the lives of people who need healthcare.
Excellent, thank you. I'm going to ask one more question because we've got to be right up against the line. I'm going to ask this to you, Chris, because I really want to include everybody in this. In your opinion, apparently this comes from Canada, do you think, I think it says substance use health as a way to move the conversation away from substance use being positioned negatively. Would you agree with changing the terminology and using medical terminology like that? Can't hear you, Chris. You're not on mute by any chance, are you? Ooh. Okay, I definitely can't hear anything here. Okay, I'm going to throw it back as a kind of the final reflections to Karen and April. How would you feel about that? Do you think we should regard it as a health issue and change the terminology as such?
Was it substance use health? It wasn't substance misuse health, was it? It was substance use health.
Substance use health was the exact words, yeah.
Yeah. I mean, I think I talk all the time about language. Every session, I mean, Tim, you know, we talk about it in the Anti-Stigma Network as well. Every session that we do on stigma, we end up talking about language, and it is really, really important. And I hope that at some point we will agree a position, but I think that position will then possibly change. So I think language is important, but as I said in my presentation, what's more important is that people feel able to speak freely and share and share ideas. Obviously, that needs to be done in a context that doesn't exclude people. and doesn't inadvertently stigmatise. But yeah, I mean, substance use health and linking that to mental health, I think, is something for us to consider.
Lovely, I quite agree. April, do you want the last word on that?
If I said not really, you're never going to speak to me again. Language is important. There is some discussion about whether substance use is a health issue. It certainly sits better there than criminal justice, I think. So considering it as a health problem or a public health problem is better than considering it as a crime and disorder problem. Or is it a society problem in how we view some drugs rather than others? And that's where I'm going to leave it.
Thank you very much indeed. I also, as it happens, agree with that. Okay, I really think I'm going to have to wrap this up, which is a shame because there's loads of interesting questions here. I want to very much thank Chris, Karen, and April for their great presentations. I love the fact you came in from different angles. That was so interesting. And for agreeing to answer the questions today. It was a real pleasure to have you join us. This concludes the webinar, I'm afraid to say. I thank you all for attending. We hope you found this informative. We hope you found it useful. You'll receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. And personally, I think they're all worth listening to at least twice. So thank you very much for attending, everybody. Thank you very much for coming. Thank you very much on behalf of the ISSUP UK. And enjoy the rest of your day wherever you are.
Thank you.